So this is a right ear, and that will be a primary surgery for otosclerosis. And I just wanted to record this one and to show you this, because the specific point that we have, as you can see, we have a really narrow of a window. We have several videos like this previously uploaded in my YouTube channel, but this one is interesting because this facial nerve, what you can see here, is dehiscent here. This part is dehiscent, you can see the bone here, but this is the dehiscent part, which is connected to the posterior crus. So of course the problem will be to remove the superstructure. In fact, in this type of situation, the first step, which will give you possibility to continue in a nice way and safe way, would be to remove the superstructure. Once we will have removed the superstructure, the gap will be much better, of course. So first step, I will check as usual the ossicular chain mobility, and so we'll start with the incuticle stapler joint separation as usual with the joint knife. And I will now check malleus incus and stapes. So you see that now malleus incus are fine and the stapes is fixed. So I would love to use the laser, but this is too small, so this is too dangerous for the facial nerve. Although I'm using a fiber handheld probe, I would say, I consider that that should be too dangerous for the facial nerve. So I prefer to start using the microdrill directly. I may use the laser for the footplate, because I think, again, once I will have removed the superstructure, the gap will remain much better to have access to the footplate. Ciseaux. Ciseaux, s'il vous plaît. Alors, la microfraise, s'il vous plaît.
Oui.
So I'm using, as usual, a 0.9 millimeter circle on my left hand and the micro drill with my right hand. A 0.7 millimeter diameter diamond dust burr. We have also a really narrow canal. It's only a 6 millimeter diameter speculum. So I always start the drilling process before reaching the superstructure in this case, and I'm controlling always. But you see, it's a different way of, in my opinion, of drilling out the superstructure. I'm not doing a right-left, but directly through the posterior crus like this, because I consider this is less dangerous for the facial nerve. You see, this is a dangerous part. Okay, I have to check now the residual posterior crus, cannelé. Yeah, we still have this, which is pretty thick. So this is really a difficult case. Vous me le changez, s'il vous plaît, j'espère pas bien. So I need to use the micro drill closer to the neck of the stapes. Encore la fraise. If I gotta break it, it's really a big one, a thick one, posterior one I mean. So I'm go here. And I'm now drilling out anteriorly. You know, I'm starting before, because if you start drilling when you're in contact with the bone, there is a risk of having a wrong movement of the bird towards the facial nerve. Alright, now the posterior crus is cut, so I will try to reach the anterior crus right now. Un micro-fraise
La
encore.
vraie?
Non, la fraise encore. Again, I don't want to use the laser. I don't have a clear access to the anterior crus, but this is really frequent, as you know. C'est un œuf que j'ai là?
Oui.
I'm trying to reach the anterior crus like this. And I'm staying on the right, of course, in contact to the promontory. I think it's nearly done. Okay, I think it's fine now. I can remove the superstructure. Trois de chou, s'il vous plaît. So I'm removing now the superstructure, and we need to check the gap we have now regarding the oval window. I will probably, very probably, use the bucket prosthesis. You know, the specific choice of prosthesis I'm doing in this situation like this. Let me explain you the problem. Calmez, s'il vous plaît. Now we have the facial nerve on the left and the promontory, of course, on the right, and this is really narrow. If I use a regular piston, then the loop will be there and the shaft will be there, so I don't like that. So I need to put this prosthesis underneath the lenticular process. This is why I'm going to use the bucket prosthesis. I'm checking again malleus incus mobility, which is fine. But first I will drill out a little bit the promontory to increase a little bit the exposure. And to improve the exposure. La fraise, s'il vous plaît.
Recette?
Non, pas encore. Un œuf encore, oui. So of course we need more time to perform the operation, the surgery in this type of situation, because everything is more tricky. So this is what I'm doing. I'm drilling out the promontory in order to increase the gap. I just want to have a safe approach to the footplate prior performing the stapedotomy. Because we need also enough gap for the prosthesis and the vein graft, because I'm still using the vein graft interposition in this type of presentation. Okay, now I think it's fine. But yeah, I think it's good enough. I don't need more. You see now the entire sucker, which is 0.9 millimeter diameter sucker, is able to go into the field, which was not possible at the beginning of the procedure. So it's fine now. I'm big enough. Now I'm going to measure now the distance from the footplate measurer to the incus. And I'm measuring as the same way, from footplate to mid-surface of the incus. But of course I will adapt the prosthesis length differently because of the use of the bucket prosthesis. So you see the second notch is in front of the incus, which means 4 millimeter, but I remove 0.5 as a routine, because the lenticular process is more or less about 0.5 millimeter, so I need to remove that to adapt the prosthesis length. Le laser. So now I can use the laser, of course, because now it's safe. So I'm using the luminous CO2 laser with the Otolaz system. Prête? Feu. Feu. There we go. We have laser spots. And now I can perform the stapedotomy. Oh, it's clear that when you do that, you cannot see exactly the field because it's really narrow. And once you put you insert the burr, the burr is hiding the field. Now you see it's starting to be fine. So I do it really regularly. I mean, step by step, I take my time to perform the stapedotomy because I just have to feel the contact with the footplate. And I cannot insert both instruments like I usually do. You know, I like to insert both the sucker and the micro drill. But in this situation, due to this really narrow gap that we have, I cannot. And of course, I'm using a 0.7 mm burr. Un peu de sérum, s'il vous plaît. Non, à côté, venez avec du sérum. Okay, I use saline solution to help for the drilling out procedure. We have quite of a really thick footplate, very strong. Vous avez une fraise neuve là, s'il vous plaît? I'm going to change the burr. I don't like this one, so I'm going to take another one. It's not really thick, in fact, but it's more a really strong, resistant footplate, a bit like a stone presentation. This is a better one. Again, you see I'm starting the drilling before touching the footplate. And it's not good to do a straightforward stapedotomy, but do it step by step. Otherwise, there is a risk of hitting the labyrinth. There we go. Now I could see the perineum coming up. So I need to enlarge a little bit the fenestra. There we go. Now it's fine. Going a little bit more, and then I will measure again because I really need to be sure about the length. There we go. Now it's fine. You see the stapedotomy, and I'm going to measure again the distance just to be sure about the length, which I think will be probably 4 again, but I just want to be sure about that, so I'm measuring again. Yeah, this is definitely 4, so I will cut it at 3.5. All right, so let's now insert the vein. And I need to insert the vein over the over window. This is a little bit more tricky to do the vein graft deposition in such a situation, but we can do it. And part of the vein will also protect the fascial nerve sometimes. It's not always easy to place the vein over the fascial nerve, but it's not bad to do it if you can. We'll try. But I'm not sure we can do that all the time. In fact, I've seen revision case where the previous prosthesis was a piston and the shaft was connected to the fascial nerve, which was Dehiscent, but I never saw any complication with that. Unless it is a teflon prosthesis, of course, because the wire prosthesis would be probably more dangerous for the fascial nerve. So again, putting the both instrument here is tricky, so we need to be very accurate with that. So I'm introducing it with the needle rather than with the sucker, which is a little bit too big with the vein graft here. But now I know it's fine, so there's no problem. I know the stapedotomy is there, so I will put the prosthesis, and the prosthesis itself will push the prosthesis in good condition and the vein graft. So this is the cutting block, and I will place the prosthesis. No, bucket. I will put the prosthesis within the cutting block, but not at 4. Remember, I measured 4, but I will put that at 3.5 because of a bucket of the lenticular process thickness or length, I would say, which is 0.5. This is a really nice prosthesis in this situation, made in teflon, same as the regular Causse piston, 0.4 millimeter, and we have this wire loop which will go over the long process of the incus. So I'm cutting it through the cutting block, and now we need to introduce it within the middle ear. You see that the lenticular process is clearly above the level of the stapedotomy. This is the reason why I'm using the bucket prosthesis there. Okay, so I'm going to introduce now the prosthesis with the sucker. And the fact that I'm using the sucker helps me, of course, just like a real instrument, because I don't need 2 instruments right now. I will need now, but not before, because I'm just using the sucker to introducing it within the stapedotomy. So I need to release the sucker, and I know by experience that we need to use the second instrument like this. Okay, so what I'm going to do now, I need to place the anterior part of the prosthesis right in front of the lenticular process. So I will rotate a little bit the prosthesis right here, like this. And now I need both hands, clearly, because we need to introduce the hollow head of a prosthesis underneath the lenticular process. So I will use a hook, Schuckness hook. No, 3 de Schuck. You see that the vein graft is covering the facial nerve on the left, which is pretty good. The tricky part here is that it's so narrow that it's going to hide my access and my view a little bit. So I'm elevating a little bit the incus, and I'm trying to introduce the prosthesis like this underneath the lenticular process. It's just pushing it a little bit like this on the left, and now it fits very nicely. You see that? And of course, again, the shaft is at a distance from the facial nerve, which would not have been the same if I was using a piston. Now I'm going to place the loop over the incus with the wire loop, which is the interesting tool. Sometimes we cannot do it when we have a really thick incus, and I must say it's not a major issue if we don't use this wire loop. Yeah, I don't think it's increasing clearly the stability of the prosthesis. Okay, and in fact there is no pressure, but I've seen cases of incus erosion even with this bucket prosthesis. There we go. You see a little bit of the distal tip of the shaft. It's very difficult to see it completely because it's too narrow, but definitely we are in a good position. You see the shaft right here, and we can look for the bending side, but you see the bending. Okay, that's fine then. I'm just going to reposition again and now you see the mobility from the mallet looks good. All right, now the procedure is just finished, so I'm going to reposition the flap. And I think it's fine, and well, I hope you enjoyed it. I think it's sometimes interesting to choose cases like this, which are difficult cases, what we also call complication in stapes surgery. So the difficulties in this situation were due to, of course, the facial nerve, but also the really narrow canal that we have. For performing this transcanal, it's not easy, but I think it's pretty interesting to show you this. And the technique I'm using, the trick I'm using for this case. So thank you again for watching, and I hope you enjoyed, and see you again very soon, I hope.